It is my pleasure and honor to be here today. A little bit of background on myself. I am born and raised in Winnipeg, and I did my medical school and undergraduate in hematology training at the University of Manitoba. And then I was fortunate during that time to work with great clinicians and researchers in CLL, such as James Johnston, who was here last time, who's been a mentor for me, and Dr. Spencer Gibson. And as you've heard, we have an exciting program, the CLL cluster, that you'll hear more about later on in the program. And so I'm very happy to be a translational researcher and a clinician. And what sets me apart, I think, in our province and our program is that my clinic is only for CLL patients, and that's all I do when it comes to my outpatient practice. And as a result, it allows me to see every person in their journey as they travel along and allow me to be part of that journey. All right, clicker. So today I'd like to describe the current treatments that are available for CLL, and I know you've heard a lot of them by name, but in this talk what I hope to do is focus on sort of why these treatments came about and how are they used, and then also some of the things that we have to take into consideration, both from the patient perspective, the disease perspective, and who we should treat and with what. So as you all have heard today, there is a diagnostic criteria for this disease, and it comes about by being able to use tests such as flow cytometry to identify what you've learned today as the monoclonal B-cell lymphocytosis. And this lymphocyte carries a particular uniform, and it's this uniform that identifies the cell as an abnormal cell. And there's a threshold you have to achieve within the peripheral blood to be considered as a patient with a diagnosis of chronic lymphocytic leukemia. But there is also a separate entity, a sister entity, that we would call small lymphocytic lymphoma. And the idea is that these abnormal cells are circulating maybe at low levels in the blood system, and you may not be able to reach that threshold. But if you examine that patient's bone marrow or a lymph node, a biopsy would be positive for this entity, and you would be diagnosed with small lymphocytic lymphoma. And what's important is that some of the treatments that we have actually are targeted to some of these surface proteins. And specifically, the CD20 is a marker of a B cell, a mature B cell, and that is really important when we think about treatments that are available for CLL. So there are a variety of management strategies, and I think it's important that these management strategies include what we call active observation, or what is typically known as wait and watch, which is a term I really don't like. I really want you to know that in my clinic or in any clinic, you're actually being observed as part of your management strategy so that we know when it's the right time, that you're experiencing symptoms from your disease, or that your disease is progressing and you're getting to a point where we need to start talking and having a discussion about treatments. So the treatments are typically for patients with symptomatic disease. And what are the symptoms that people might have? And these would be, either you're too tired or you're having what we call B symptoms, or what are traditionally known as cancer-related symptoms: nausea, vomiting, fevers, chills that are not explained by a flu or some sort of other illness. But we're looking for things that are causing you to become run down over time. The other thing that might happen is people might feel completely well, but then they start having infections and their body's not working the same way as it used to. They used to be able to fight things off, but all of a sudden over time, regardless of age or other things that also contribute to our ability to fight infections, this ability is starting to decline. And this might be a sign that your disease is progressing. And finally, advanced stage of disease. So when we get to those rise stage 3s and 4s, we're always debating as to, even though people might feel well, when's the right time to treat them? But those thresholds start to have an impact on your body. Those hemoglobins in the 110s and the platelets in the low hundreds might start impacting how your body functions on a regular basis. And as a result, we need a reset and a way to treat you. So what is leading to this disease? And I think this is important. you have blood cells in your body, and their normal job is to fight off infections, especially the white blood cells. And with the lymphocytes, it's typically viral infections. But those lymphocytes have timed life cycles. There's a balance of cell survival and cell death. And there's also a balance of growth and no growth signals. But in the CLL lymphocyte or the SLL lymphocyte, those scales have tipped, and tipped in the favor of cells escaping the death signal or continuing to grow. And this is important in what led to the discoveries of different treatment strategies for patients. The other thing that CLL cells have is a nurturing neighboring environment. So these cells are well protected and well nourished by the environments in which they grow, whether that is the bone marrow or the lymph node. These signals allow them to move freely amongst the systems, but also have signals that allow them to proliferate and grow. Within the cell, there is also a nurturing environment, an internal signal that propagates the growth signals. And I know that this type of a diagram can be quite scary, but I think it's also important to understand that the nurturing environment can signal through these different receptors to promote the CLL cell's growth and survival. And some of the proteins that are indicated in this cascade are some of the very proteins that can be targeted by some of the novel agents we have today. So in particular, the B-cell receptor signaling pathway, the BTK and the PI3K are really the targets of some of the novel agents that have and will be discussed today and further, specifically ibrutinib targeting the BTK inhibitor, which is a first-generation drug, and acalabrutinib, which is a second-generation drug, and then Idelalisib targeting the PI3 kinase pathway, which have both had success in the treatment of CLL. So this is the evolution of the CLL therapeutic toolbox. And when I first started my training as a medical student, and I was in the clinics of both Dr. Israels and Dr. Johnston, Dr. Israels was one of the founding members of the CLL research group in Winnipeg, but he was also the gentleman that brought chlorambucil back to Canada in his suitcase from England. And so I was one of the first people that had the opportunity to use these medications. And when I started, we were doing a combination of an alkylating agent and prednisone. Those were the treatments that were available about 20 years ago as I started my medical career. And all I've seen over time is an improvement in the availability of different chemotherapeutic agents, novel antibodies, and targeted agents, leading to small molecules that have now been able to target some of the main pathways, such as apoptosis, which are the Achilles heels of CLL cells. And now we're in the era where we're combining these treatments left, right, and center, and I can't even keep up with all the different trial names. But all I can say is that this is the sign of progress. And in 2016, ASCO named CLL the disease with the most progress. And for me, it's the disease that has now offered hope to patients regardless of where they are in their disease course. And that is something to be celebrated around the world. So when it comes to what are the treatment options available, I think we are still looking at a very heterogeneous disease where there's multiple patients who are at different aspects of their journey. And so depending on where you are in your journey, some of these treatment options are going to be relevant to you. And although you've heard a lot about the different treatments already by name, I thought it was important to sort of explain some of the elements as to why we started using these treatments. And it's really important to understand that in general, a cancer cell is a cell that can replicate. And when it replicates, it requires the DNA to be able to multiply and then divide into a subsequent cell. Now, when we think of different types of treatments that are available, they can target different aspects of this machinery. And so cyclophosphamide and chlorambucil can cross-link the DNA, cause damage, and then basically cause that cell to prevent itself from replicating. fludarabine can insert itself into the genetic code, and therefore your genetic machinery can't read that code anymore, and therefore it stops the replication on that aspect. Bendamustine is kind of fancy. It actually has both of those capabilities, and we still don't really know how it works, but it does work. But as a result, these treatments, although have been identified in treating cancer cells, every cell in your body can replicate using this machinery. And that's what makes these treatments less targeted, and that is what may lead to some of the side effects that we see in our patients. And so these are typically some of the backbones of the chemotherapies that we would offer to patients. So monoclonal antibodies. Monoclonal antibodies are really what were, in my mind, the beginning of designer drugs. They were targeted to certain proteins that were on the surface of your CLL cell. And so particularly, most of you are familiar with the ones targeting CD20, and the most common and the most used worldwide is Rituximab. But at a time when we did not have novel agents to treat relapsed CLL, we were using other monoclonal anti-CD20 agents such as ofatumumab. But recently in the frontline setting, we've now had approval of a very new CD20 antibody that might be more effective and is maybe a little bit more toxic at the same time, but obinutuzumab in the frontline setting for frail elderly patients with CLL. And again, in the relapse refractory setting, there's also a monoclonal antibody that targeted the surface marker CD52. And that was something that was used prior to the availability of some of these novel agents, but again, with a lot of toxicities and infections related to it. So the opportunities we have now are better than what we had previously, but these were some of the main treatments that pioneered the way for targeted agents. And then the newest agents that are targeting some of the biology of CLL cell survival are the B-cell receptor signaling pathway agents, or BCRI, as you might be hearing. And the reason these have been important is that they've changed the way we treat patients with CLL and think about treatments in patients with CLL. And the reason for this is that we've moved to something that was a time-limited treatment with a restricted number of cycles to something that is more of a chronic suppressive therapy akin to treatments like diabetes and hypertension, where your disease is managed with chronic treatment. And so these agents are typically ibrutinib, which is very well known, and idelalisib, usually in combination with a monoclonal antibody such as rituximab. And these agents basically cut the signaling ties of the CLL cell from the microenvironment, which is found within the lymph node or the bone marrow, which is often one of the areas where resistance occurs even after chemotherapy, because we're not able to sever those ties in a way that leads to a durable response. And then finally, what everyone is celebrating today is the approval of a drug known as Venetoclax. Venetoclax is really a novel agent. We've known forever that CLL's biology is the ability to escape apoptosis. And this is done by the presence of upregulated anti-apoptotic proteins. And Venetoclax is really the agent that has now come to clinical practice, in which it's targeting these anti-apoptotic proteins, which enable the CLL cell to apoptose and then die, which is a novel way of treating CLL that we've never had before. But with these new drugs comes a waterfall of responsibility and questions, because we are in an environment where we want the best for our patients. We are in a publicly funded healthcare system, as Carolyn has mentioned, but at the same time, we want to provide our patients and advocate for the best care possible. So what I thought I would focus on right now is sort of the regimens that are currently available for the treatment of CLL and how we might be using them in the Canadian environment. So I've just listed them here, and basically they're grouped by availability and also by the category of patient and the characteristics of patients that might use them, and we'll go into more detail, but this is just a summary. So I've mentioned all the different drugs, but basically FCR, or fludarabine, cyclophosphamide, and rituximab, bendamustine, rituximab, and fludarabine and rituximab are commonly used in fit young and old patients. Chlorambucil, obinutuzumab, or chlorambucil and rituximab in less fit patients, and in those patients who are deemed to be not able to tolerate combination chemotherapy, chlorambucil and ibrutinib. So, and in the relapse setting, there are some patients that may be eligible for chemoimmunotherapy, but I believe that this is a very small number. But mostly single agent ibrutinib, Idelalisib and Rituximab, and Venetoclax are the agents available in the relapse setting. So what are the factors that influence my decision? And these could be divided into three categories. One is the patient characteristics, the other are the characteristics of the CLL itself, and then finally the drug characteristics, because we need to make sure that we are using the right agent for the right person. So when it comes to the patient characteristics, basically, we've divided in the frontline setting whether or not patients should be in a category where they're less than 65 or greater than 65. And this is important because the treatments that we would have in the younger fit patient are very, very rigorous to go through and can have high side effect profiles. And as a result, someone needs to be medically fit to go through them. And it also makes a difference because we haven't talked about this yet because we're excited about all the new medications, but there are some patients that may still need to go on the journey to a stem cell transplant. And for those patients, there is a cutoff on who should go to transplant. And we need to keep that in the back of our minds, although there is a new amount of treatments available. The next thing is fitness. Now, classically in clinical trials, fitness has been evaluated using the comorbidity index rating scale. And it really is a questionnaire that can be very long or very short, depending on what you look up on the internet. But it's asking you about what your medical illnesses are. And are you on treatment for those medical illnesses? Because that really gives us an idea of whether or not you're fit for the particular treatment we have outlined. As Carolyn said, there's nothing that has been approved, but it is what we're most familiar with because this is what has traditionally been done in the clinical trials that we do run at our institutions. There is a huge movement looking at frailty index in patients with cancer, regardless if it's solid or hematologic, and it's something that we're actively looking at our institution as well, so that we can find the right way to classify patients based on their medical illness, so that we're not inappropriately categorizing someone as being fit or frail when they're actually not. And so I think it's a really important thing that needs to be evaluated as our patients are getting older. They might have more medical problems, and we don't want to subject them to undue toxicity of treatments. And then finally, in order for some of these drugs to be processed by your body, you need to have organs that are able to metabolize the agent. And so some of the drugs are cleared through the kidney, and some of them are cleared through the liver, and as a result, we need to look at those functions to make sure that your body is working so that you're not getting undue toxicity because of the fact that the drug is accumulating in your blood system. And then there's what we call disease-specific characteristics, and you've heard a lot about this already. And in that regard, what I think I will just mention here is that we do require and have patients tested for FISH upfront in Manitoba at the time that they need treatment. So we don't do it at diagnosis, but when we're making a treatment decision, we will do their FISH testing. And so we really want to know, are these patients 17p deleted? One of the things I wish I had access to, but I don't, is P53 mutation testing. So as sequencing becomes standardized across provinces, and it is being standardized for solid tumors, and they are looking at the P53 gene on those sequencing panels, I think we will have access to it very rapidly, but we are currently not at the point where it's available for CLL testing, at least in my institution. And then the IGVH mutational status, and the same applies. We do have the availability to send off the IGVH mutational status so that we can look at it, but currently our practice does not enable us to look at it at this point in time. And this is new, and you saw it on the Lymphoma Canada website that says that this testing is now available. So we're all working towards using this moving forward. So the other thing that I think is really important is that I live in a province of 1.2 million. I know that's small in the Ontario-Quebec realm, but I service a geographic area that extends into northwestern Ontario, Nunavut, and the entire province of Manitoba. And actually delivering the care is a discussion I need to have with my patients. And people come from all aspects of the province to actually come and see us at the CLL clinic. And so when it comes to what are the factors that need to be considered is how are those drugs delivered in those communities? Can they get that drug in their home community? And sometimes that's not the case, and that might actually factor into a patient's decision making. Do they want to travel to our institute every time? The other thing is the frequency of visits, the monitoring. We've changed from something that was 6 cycles with a once monthly visit to something that requires in our clinics at least someone monitoring the counts on a weekly basis initially, making sure that there's no side effects. We're using resources in the laboratories to test the blood counts on a more frequent basis. And then we would like to continue to monitor you on treatment throughout your journey, which I think is important so that we capture any side effects or any resistance that may be occurring. But it really is something that the patient needs to understand. And then with the new agents, some of the drugs cannot be delivered safely in the outpatient setting. And we'll talk about why that is in a minute, but that's a consideration. Is your cancer center a hospital that can admit patients? If you are, you're lucky, because I'm not. I have to beg for a bed if I want a patient that needs to be admitted for a treatment. And I think that as something that as these new medications are coming up, we need to advocate for our cancer systems to have an open communication. But it does come into play in terms of, do patients want to stay overnight at my hospital opposed to being in their own institute? And then the other thing are the toxicity profiles. And this is related to the particular side effects that each of the treatments might have. And we'll go into that with each particular drug. And then how do they relate to their medical conditions? So I'm not going to go into much detail about this because there's well-established evidence that Carolyn has already presented. But the upfront standard regimens for patients who are fit and have good renal function and are less than 65 years of age is fludarabine, cyclophosphamide, and rituximab. And in those who are older than 65 but still considered fit, bendamustine and rituximab is one of the options considered. Chlorambucil and obinutuzumab is those regardless of age, but if they have multiple medical issues would be considered. But obviously, I always advocate if there is a clinical trial available that we as physicians and providers always discuss clinical trials with our patients. Oops. All right. This is a review article that was written by Dr. Owen, and I think it reminds me every time of, for the response that I'm getting, what is it that the patient might endure? And I think this is a really good evidence-based review of how with every treatment benefit comes a cost and toxicity. And so we really need to be aware that although we're trying to strive for the best results when it comes to treatments for our patients, it comes at a significant price in the toxicities that they might endure. And so educating them about those toxicities, as you can see, and these are not just grade 1 or 2 or things that we can resolve very easily. These are significant toxicities that might end up requiring either IV treatments or hospital administration. And I think that's a really important thing to think about when we're trying to pick what's the best option. And that's where although we've been saying that personalized medicine is coming, I have to say that we've been doing this in CLL for a very long time. So the other treatment that I think is now available in the frontline setting is ibrutinib, and that is really in patients who may not be candidates for chemotherapy, and we still have to look at that as an option. And although the comparator arm in this study could be debated because now chlorambucil and obinutuzumab has been, oh my goodness, I just got the 5-minute symbol. I'll go fast because Carolyn talked about this. This is definitely an option. So, how does deletion 17p alter this? And the reality of the situation is I do avoid chemoimmunotherapy in patients, and for the reasons that Carolyn has actually alluded to. And there was a really nice review written in the ASH education book this last December, which I would highly encourage anyone who is interested in where they go through all the data and why it's important. And the same thing with mutational status. We do not have the full access, but I do believe for patients who are mutated, knowing this actually gives us the confidence that treating these patients with frontline therapy with FCR, really they can have a potential cure from this. So this is the treatment algorithm that is currently in existence in Manitoba right now. So, I put this up. This is the Museum of Human Rights in Manitoba and in Winnipeg. And really, it's called the Tower of Hope. And I really do believe we're in this era of hope. Because in the relapse refractory setting, we have not, I know it looks dreary, but it's actually really nice. The relapse refractory setting, the treatment options have exploded. So some of the things that we've had to work out is that that we have these drugs available is the sequencing of these drugs. And for the most part, I think knowing that you're 17p deleted, ibrutinib is our treatment of choice. And then it becomes one of the BCR targeted agents. And in those who have failed either, it's Venetoclax. And selecting these treatments depend on multiple things, including the genetic mutation and the side effect profile. So the BTK inhibitor, ibrutinib, is a single agent. It's taken as 3 tablets once daily until progression. And it has had extreme success when looking at the relapse refractory setting and whether you're 17p deleted or not. And with this, it's become standard of care in the relapse refractory setting. But what makes it hard is actually the side effect profile. It's not the efficacy of the drug. So initially when this drug was introduced, the lymphocyte count was something that scared people, but really we know it's a marker of cells evading the microenvironment. But what was less known was the irregular heart rhythms and the bleeding that really do make using this drug a challenge in patients. But we have to inform them of the side effects, and in all honesty, with a large group of patients who I have on this, they're able to tolerate the medication, but at the same time, we do have to work through some of the side effects. But this makes picking this drug, we have to pick the right person for this drug. And like I said, monitoring has changed. And so we have a schedule that we've created where, at least for the first month, while we're trying to work out how patients do on the full dose of the treatment, how do we monitor them? The next line of treatment or next available treatment is Idelalisib and Rituximab. I will say that we've tried very hard to have patients treated with this regimen, but we've had difficulty because of the toxicity profile. But it is available in this second line setting for patients who are definitely not a candidate for ibrutinib. And again, we have the monitoring schedule that we use in our institution, but the side effects are what make this drug also challenging. And this is typical for tyrosine kinase inhibitors, which is diarrhea, but the ones that are unpredictable are the inflammation in the lungs and some of the mood changes and the changes to the diabetes. All right, so Venetoclax, which everyone's going to want to hear about. So this is what is now available for us in patients who have relapsed after treatment with a BCRI or who have progressed on or are intolerant of a BCRI. And so there's excellent data supporting the use of these patients in this small group of patients, and this is truly an unmet need. And it allows us to actually have a little bit more flexibility in treatment options for our patients. The one thing about Venetoclax is that it does go through a ramp up in terms of how you give it, and this is because of the risk of tumor lysis, which we don't usually see in our patients with other treatments. This is what makes this drug difficult to administer in the outpatient setting and requires other care. And then some of the side effects that we know of at this time are really related to low blood counts and the tumor lysis. So this is the schema for the relapsed refractory setting that we have at our institution. And so just to be aware of the Canadian environment, these are the costs of each of the 28-day cycles of these regimens, which is borne by the majority by our healthcare system or private insurance if you are lucky to have that. And then I mentioned allogeneic transplant. So in summary, many options are available compared to before. We are still learning what is the right fit based on the patient and disease characteristics. And we are moving to chronic suppressive treatments at this point in time, but we haven't stopped here because we're now looking for a way to find a cure and potentially be able to have drug-free periods for patients. And with that, I will end.
I was hoping you could talk a little bit about trials, not necessarily specific drugs, but what are the circumstances for someone being a candidate, and what could the potential risks be for that patient?
Absolutely. So trials are an avenue for us to usually test drugs that have either never been tested together before or bring new agents to clinical practice that we think are going to be effective. Typically, depending on the setting, if it's a frontline setting trial, you can't have had treatments before. You typically have to be over the age of 18, and often they say that you can't have an active other type of cancer. And then they usually would exclude patients who have had any treatment at all, even if it was chlorambucil years ago, but sometimes that can be argued. So really, for the most part, as long as you're someone who could answer the question we're trying to ask, the inclusion criteria and you meet the diagnostic criteria of the disease is very broad. The exclusion criteria are really based on what question you're asking. So if it's a relapse setting, you have to have had treatment again. So it's a very particular design. The opportunities really depend on where you are, in all honesty. So the bigger the center you're in, the more access you will have to clinical trials. And that could be at any stage of clinical trials. So clinical trials can be considered early clinical trials, so drugs that are just new are maybe first in human and moving up to understand the toxicities, and then look at what we look at in terms of efficacy. And then there's some that are, we know that these are safe, now we want to use them, and we want to prove that they're better than the other drugs that that are out there. So often you need to be in a phase 1, phase 2 center to have access to those early drugs. Phase 3s are often more common across the country and other centers. It's really hard if you have a remote population like I do in Manitoba. If patients are in rural communities, they want to come and participate in a trial, they would have to drive in, do all their visits with me, and then drive back. So there can be issues related to logistics because not every satellite center might be approved for that trial.
I've had CLL since 2000. I was treated in 2007 with just fludarabine. So how does that play into follow-up treatments as the regimens are looking at FCR as a first treatment?
So that would also depend on your age and eligibility for FCR. Some people would say that if you've had a long remission and never needed anything, that we would still try a chemotherapy-based treatment with an antibody attached to it, knowing that you might not respond well to it, but you may have that ability. Obviously, we would test your genetics to see if you're 17p deleted, or in that case, if you were eligible for FCR mutated, to make that decision. But you would be, I think we would take the opportunity to look at repeat chemotherapy before we move to the novel agents. So we still had those novel agents for you in the future if you did progress.
You mentioned people in isolated areas having less access. I'm wondering, say, if I lived in Churchill and I've been diagnosed, is there some sort of provincial funding that would pay my airfare down to Winnipeg?
Oh, you're covered for regular routine medical care. So I have patients in Churchill and Nunavut, and they come and see me for their routine care. When it comes to clinical trials, it's a little bit different because there is travel allowances that are often part of the contracts that the agency would have, but they often will not cover these large amounts, which is almost a flight to Vancouver or more based on my location in Winnipeg. So, but the access is there. So we are able to communicate with in-person visits. If it's a routine follow-up and I don't need to do a physical exam and I'm just watching the blood counts, I do telehealth visits. So we have ways to connect everyone in our province so that they are all getting the same access to us as physicians.
I'm in BC, and I was just wondering, do I have access to any of the clinical trials that are happening perhaps back here in Ontario or, in Manitoba? Can I be a participant in those clinical trials, and what would be, yeah?
So for the most part, the answer to that question is if you're eligible for the trial and I'm not offering it in my home province, and I think that you would be a suitable candidate for that trial, I could send you to be evaluated. But I think the costs are borne by the patient in order to travel back and forth, and it depends on the schedule of the trial if it's even feasible, unless you're willing to relocate temporarily for that purpose. Thank you.